back for your third day, and then some of you are just joining us for the first time today, so welcome. Those of you that were here yesterday had the pleasure of hearing Dr. Jason Schillerstrom, and he's back with us again this morning for 2 additional presentations. And so since some of you weren't here with us yesterday, I'm going to go ahead and introduce him to you again. Again, this is Dr. Jason Schillerstrom, and he's an assistant professor of psychiatry at the University of Texas Health Science Center here in San Antonio. He completed medical school, his psychiatric residency, and geriatric psychiatry fellowship training also at the Health Science Center. He is a diplomat of the American Board of Psychiatry and Neurology, and he's board eligible in geriatric psychiatry. Dr. Schillerstrom is involved in multiple teaching, research, and clinical care activities at the Health Science Center, including the establishment of a geriatric psychiatry clinic that specializes in cognitive impairments and depression in elders. He has multiple scientific publications and is currently involved in research protocols measuring the impact of medical illness on cognition, the association between depression and increased disability and mortality, as well as clinical trial research for Alzheimer's disease. It is a pleasure to have him with us again this morning. Please give him a warm welcome.
Thank you all again. I always thought, again, I always love these introductions because they always go on forever. I thought like my wife introduced me. She'd probably say, "Here's my husband. He lets the grass get a little too high in the spring. The kids say he grows like a girl, and I wish he'd bring dinner home every once in a while." So I appreciate the kind words. So we're going to start off with the hardcore topics right off the bat. Dementia with Lewy bodies. And so there's lots of different types of dementia. And I think patients really have a hard time understanding that. They'll come in and they'll want to know, well, does he have Alzheimer's disease or does he have dementia? And so we kind of have to go through the diagnosis and say, well, there's dementia. There must be 100 different types of dementia. Alzheimer's disease is one of those, but another one is Lewy body, and it's one that's getting a lot more recognition lately, mostly because of the toxicities that a lot of our treatments have on patients with Lewy body disease. And so it's becoming more and more important for us to recognize this dementia and to appreciate that it is a different disease process, and that because it's a different disease process, it has different treatments, and if we use the same treatments, we may get very different effects with Lewy body disease compared with, perhaps the more prevalent Alzheimer's disease. So before we begin, I'm just going to read you a letter. You know you've made it as a geriatrician when you are on your patient's email server to their children, right? And so the letter goes like this. Let's see. One afternoon, the sun was still shining, and we were sitting in the living room. Don said, "Now I don't like that," and jumped up from his chair. He exclaimed, "That man over there is looking at us straight in the window." He cupped his hands in a partial fist and held them to his eyes. I asked, "Is he using binoculars?" And he said, "Yes, and he is wearing a white sheet and a hood, and 2 little boys are with him." I asked, "Are they on this side of the truck in the driveway or the other side?" He answered, "This side." Of course there was no one there, so I suggested, "Darling, if you sit down, perhaps he'll lose interest and go away." So he sat down, and in a minute he said, "He's still there, and now he isn't. It must have been a hallucination." He continued, "I spoke too soon. There he is again. Now he isn't. He's staring at us again. Darling, why don't you read and ignore him?" Well, that didn't work, so I just closed the drapes. Now the next job I have to do is to get the sheer back up so he can't see so well. He didn't like it a long time ago because he couldn't see. I'll tell him we really need it because of the heat. Yes, we have solar screens, but this window could also use a sheer. Don sees gorillas or chimpanzees in the backyard, and other animals too. One day he went out to check out a cat, and he thought it had been injured. I saw Don way out by the back fence. He walked around the fence line. Finally he came in the house, just a mess. He had come right up behind the house, still looking for that cat, and had slipped on some pretty loose bricks repairmen had left. He was scraped and banged up pretty badly. He never did find his injured cat that he saw. He tried to get me to see the cat. See, he's back there by that rock. There was no cat there. I just told him I couldn't see it. He has hallucinations quite often and regularly. Now Don has started becoming lost in the house. How do I get to the bathroom from here? One night he stood in the hall and I asked what he was looking for, and he said, I can't find my bed. Tonight he wanted to know, where is the new bed that we just put inside this door? He was looking and pointing to a place in the office. I asked him to come and stand by me. He did, and his extra long new bed was inside his room behind a different wall. He also asked, where is the bathroom from here? I tell him just as if he were a guest in our house that needs to know. Don has to be bathed most of the time, unless he takes a tub bath, and then I wonder how clean he is. I do have to help him dress. When we go to the store, well, anywhere, he always trails behind me. He's very confused, at least 75% of the time. He will start to talk and loses his thought in mid-sentence. Or sometimes I can't understand the thing he says. He sleeps a great deal of the time. This is a letter from a patient of mine, the caregiver, the wife of a patient of mine who has Lewy body disease. And so just kind of from the beginning, from reading that letter, is there anything that just kind of strikes you as how patients with Alzheimer's might be different? How might patients with Lewy body be different from patients with Alzheimer's disease? Any thoughts from that letter? So hallucinations are the big one. So in that letter, one of the things you see is he has just profound visual hallucinations, gorillas and chimpanzees. Did anything else strike you?
But he knew he was having hallucinations.
There's some insight. Yeah, there is some insight. And so with him, if he sees gorillas in the backyard, he knows that there's not gorillas in the backyard. But if he sees a cat, well, he's not so sure. You know, that might really be a cat. The other things that'll come out are that, he's confused 75% of the time, which suggests that 25% of the time, he's pretty good, right? And so you kind of start to see these fluctuations in confusion. And then the other that sort of got mentioned in there was the falls. He stumbled over some bricks or something that had been left behind. That's another key feature of Lewy body disease we'll talk about is, these really are the patients that fall. The Lewy body patients are the ones that are at the highest risk for falls. So we'll talk about that. All right.
Is it turned on?
We're going to talk about dementia with Lewy bodies. I want you to be able to describe the diagnostic criteria, discuss the clinical features of dementia with Lewy bodies, and then distinguish those criteria from Alzheimer's disease. We'll talk about the pathological changes associated with dementia with Lewy bodies. And then we'll discuss treatment strategies, most of which are off-label for dementia with Lewy bodies. I should have put a disclosure slide in here since we're going to be talking about treatment. I'm not involved in any Lewy body clinical trials. There's some Alzheimer's clinical trials that we do, but they're not relevant to this talk. Okay, so the diagnostic features. There's a consortium for every disease, and so the consortium of Lewy body came up with these criterion for Lewy body disease. And so the central features are that a person has to have progressive decline sufficient to interfere with social or occupational function. They have to have memory impairment, and then they have to have deficits on tests of attention, executive function, which we discussed and we'll discuss again in the next hour, and visual spatial ability. And so essentially the central features just say that the person has to have a dementia. They have to have a cognitive impairment, they have to have functional loss, and the cognitive impairment has to be causing the functional loss. But then you get to the core features. And so the core features, or the core features diagnostic criteria for dementia with Lewy bodies are Parkinsonism, visual hallucinations, and then fluctuating cognition with variation in attention and awareness. And so there's different, depending on the group that you talk with, there's different ways that these criteria are satisfied. But in general, most will say that if the person has 2 out of 3 of these, then they have dementia with Lewy bodies. So 2 out of 3 suggest dementia with Lewy bodies. So that would be an REM sleep behavior disorder, and we'll talk about that. REM, just real briefly, REM sleep disorder is when your brain fails to paralyze your muscle tone during REM sleep. So when we enter the dream stage of sleep, our muscle tone in our body becomes paralyzed. But in REM sleep disorder, it doesn't. And so these patients will just thrash all about as if someone is very sensitive to neuroleptics, and so neuroleptics are antipsychotic medications. These are the dopamine blockers like Haldol, Risperdal, Zyprexa, Seroquel, some others you've probably heard of. If someone is very sensitive to these medications, if they get very stiff, if they tighten up, if they can't tolerate these medications at all, you start to think about Lewy body. And the last one is more of a research feature. If they have low dopamine uptake in the basal ganglia, demonstrated by neuroimaging on PET scan. Neuropsychologically, when we give these people cognitive batteries, if we were just to take a person with dementia with Lewy bodies, refer them to a neuropsychologist, and have them give these 6-hour extensive cognitive batteries that they'll get, what we find is that patients with dementia with Lewy bodies have greater deficits in attention and visual perception relative to patients with Alzheimer's disease. So their attention processes and their visual perception is poor relative to those with Alzheimer's disease. In contrast, Alzheimer's disease is associated with greater deficits in memory and name. So patients with Lewy body dementia, they have to have memory impairment. You can't have dementia unless your memory is impaired. But relative to dementia with Lewy body patients, patients with Alzheimer's disease, their memory is much worse, particularly at the earlier stages of the disease. At the late stages, after someone's had this for years, memories may be equivocal or maybe equal. But in the beginning stages, memory is relatively preserved compared to Alzheimer's disease in patients with dementia with Lewy bodies. And so if you look at, this is just an example of that, where this group here, they took about 87 dementia with Lewy body cases. They take about 138 Alzheimer's disease cases, and then they compare them to normal controls. And so what you'll see is that when you look at let's see here, the mean age, the ages are about the same. 73 years old for Lewy body, 73 for Alzheimer's disease, about 5 years older for the normal controls. And their education levels are about the same. And then give them this big old cognitive battery, and you can, just to kind of, as a reference point, you can look at their many mental state exam scores. So the dementia with Lewy body cases, they're scoring a 23. Remember, a 24 is a typical cut point. If someone scores a 24 or less on the mini mental, we get concerned about dementia. So the Lewy body patients are scoring a 23. Alzheimer's diseases are scoring about the same, no statistical difference there, 22. And then the controls are scoring 28. When you look at the memory tests, however, logical memory, and visual learning test retention. What you see is that the Lewy body patients are performing better than the Alzheimer's patients, but both are performing worse than the normal controls. And then when you get down to the processing, visual processing tests like trail making part A, you see that the Lewy body patients are doing worse on visual processing than the Alzheimer's patients, but both are still doing worse than normal controls. So again, in general, these Lewy body patients tend to do worse on measures of attention, visual processing, even executive function, relative to Alzheimer's disease patients who tend to do worse on memory and ability to name objects. We can talk about the cerebral and structural differences. So if you were to look at just the brain, if you were to compare brain structure and brain physiology between these two patients, between Lewy body patients and between Alzheimer's patients, what you'll see is that patients with Lewy body disease, they have what are called impaired saccadic eye movements. Their eyes don't track as well. They can't follow objects. As objects move through space, they can't follow objects as well. So they have impaired tracking abilities. They have decreased occipital blood flow. And you'll remember occipital cortex, that's where visual centers are. And then probably the most important difference between these two groups is that patients with Lewy body dementia, they have very early onset cholinergic loss. And so kind of what was hoped with Alzheimer's disease was that cholinergic loss would explain it all, and then medications that increase cholinergic tone, like Aricept, for example, would help patients with Alzheimer's disease. In Alzheimer's disease, you don't get cholinergic loss until much later in the disease, compared to Lewy body disease, where you get cholinergic loss much earlier. And so what that suggests is that maybe acetylcholinesterase inhibitors, like Aricept, or Razodine, some of the others, maybe they are more helpful for Lewy body patients, perhaps. And so the other difference that we'll see with Alzheimer's disease is they have greater hippocampal atrophy. The hippocampus is the brain structure that encodes memory. And so again, we would expect that patients with Alzheimer's disease will have worse memory function compared to Lewy body. And when we do the cognitive testing shown on the previous slide, they do. We're going to talk a little bit about each of these core features. We'll begin with Parkinson's. And so the classic signs of Parkinsonism are pill rolling tremor, masked faces, shuffling gait. They'll be kind of rigid. If we move their arms up and down, they start to cogwheel. And so in dementia with Lewy bodies, in patients who have dementia with Lewy bodies, the cognitive deficits are more closely associated with rigidity and the bradykinesia. And so the more rigid a person is who has dementia with Lewy bodies, oftentimes the more cognitively impaired they are. Or they're just slowed down, the more their gait is impaired, the more cognitively impaired they are. Tremor doesn't really seem to predict the level of cognitive impairments in dementia with Lewy body cases. And a lot of my Lewy body patients, they don't have the tremor at all. It's we have to move their arms up and down and see if they have that cognitive, see if they have that rigidity. It's more symmetric compared to patients with Parkinson's disease. Parkinson's disease, you'll have, the right side will start to tremor, and then maybe later on the left side will catch up. In Lewy body cases, it seems to be symmetric. Both halves of the body are deteriorating at the same rate. It's associated, Lewy body disease is associated with more gait abnormalities. And it's also less responsive to medications that are commonly used to treat It's less responsive to medications that are commonly used to treat Parkinson's disease, like carbidopa. The visual hallucinations, I think, are probably the most striking feature of this illness. And what patients will see are fully formed, detailed, three-dimensional objects, people, or animals. So these aren't shadows, right? So sometimes in my clinic, I ask people, have your minds ever played tricks on you? Will your mind ever play tricks on you? And they say, well, sometimes I'll see a shadow. And these aren't shadows. These are gorillas, as suggested by that letter. These are chimpanzees. These are cats. These are people, right? These are fully formed, clear as day, three-dimensional visual hallucinations. And so they occur in 60 to 85% of autopsy-confirmed Lewy body cases. They occur early in the course of the disease. Patients with Alzheimer's disease can have hallucinations also, but those hallucinations tend to occur much later. In Lewy body, it occurs generally right around the onset of the cognitive decline. And so hallucinations occur early in the disease, about 80% in autopsy-confirmed cases. And again, I can't stress enough that these are, you don't have to guess. You don't have to say, well, maybe it's a hallucination, maybe it's not. It either is or it isn't, right? These aren't subtle. And so possible causes for these hallucinations, it's generally thought that the severe depletion of acetylcholine that occurs early in the disease is what's responsible for these hallucinations, which would be from nucleus basalis of minor or basal forebrain dysfunction. What's an interesting thought is that in your normal sleep cycle, you'll have acetylcholine neurons. So these acetylcholine neurons, they are activated when you're awake to maintain attention, and they're activated also during REM sleep, but they're shut off during non-REM sleep. And so what we know about Lewy body patients is that they have these REM sleep behavior disorders, and they have these just profound visual hallucinations. And so some have suggested that this dysregulated REM sleep, it suggests the possibility that these visual hallucinations that they're seeing are intrusions of dream imagery. And I don't know if that's true or not, but I think it's an interesting idea. The second core feature the third we'll talk about is fluctuations. And so Lewy body, it mimics delirium in that there's waxing and waning of cognition, behaviors, and arousal. This is probably, this is the criteria when there's these consortiums on Lewy body and they talk about these three, Parkinsonism, hallucinations, and fluctuations. This is the one that's always kind of the weakest. It's the one that they tend to, they keep around because it's there, but I think one day maybe they'll get rid of it, or maybe they'll add another criterion in there that's a little bit stronger. This is of the three, this is the 10 to 80% with poor inter-rater. It has very poor inter-rater reliability. It's hard to elicit. The way we elicit it in our clinic is we'll just ask our patients, or we'll ask the caregiver of the patients, does your loved one, do they have spells? And we'll just say it as vague as that. Do they ever have spells? And if they say, well, what do you mean by spells? Then the answer is no. They don't have it, right? But if they say, oh yeah, they have spells, and let me tell you all about them, then they clearly do, right? And so in research instruments, sometimes what they'll do is they'll ask these 4 questions here, trying to elicit fluctuations. They'll ask them, does your loved one, do they have daytime drowsiness? Do they have daytime sleep of 2 hours or more? Do they stare off into space for long periods? Are there times when the patient's ideas are disorganized, unclear, or illogical? So they'll ask these 4 questions, trying to get at fluctuations. Again, this is, the Parkinsonism, the visual hallucinations, and the fluctuations. This is the criteria that's really the hardest to assess. If someone has 3 out of 4, if they answer 3 out of 4, a yes to 3 out of 4 of these, and that has an 83% positive predictive value for spells or fluctuations relative to clinical energies. So these are some, if you're trying to get at fluctuations, these are the 4 questions that are often asked in research studies. Other features. And so, in addition to those 3, hallucinations, Parkinsonism, and fluctuations, there's other features that just seem to be more common in patients with Lewy body dementia. One is that they just have excessive daytime drowsiness. And so 75% of patients with dementia with Lewy bodies have nighttime arousals. They just wake up inappropriately all the time at night. And so perhaps that's the reason that they have this excessive daytime drowsiness. Patients with Alzheimer's disease, at least in the earlier stage, they don't really have that. They'll be awake during the day, putzing around, doing their thing. They may take a nap. But then patients with Lewy body dementia are much more drowsy during daytime periods. Again, they also have this REM sleep behavior disorder. And so, again, what that means is augmented muscle activity and dream content typically precedes the onset of dementia, hallucinations, and Parkinsonism. And so, again, during normal REM sleep, the brain shuts down muscle tone to your trunk and your extremities. And patients with Lewy body disease who suffer REM sleep behavior disorder, the brain fails to do that. And so they'll just be thrashing all around in bed. And so one of the questions I ask when I'm trying to figure out what type of, is it Alzheimer's disease, is it Lewy body, what is it? One of the questions I'll ask the caregivers is, well, tell me about their sleep. And then what I get to is, do y'all sleep in the same bed? And so with patients with Lewy body disease, the answer is almost always no. And then the follow-up question is, well, why is that? And they'll say, well, they just thrash around and they're hitting me, and I mean, they'll get like black eyes and bloody noses. I mean, it looks like they've been in a war when they wake up in the morning. And so REM sleep behavior disorder, just thrashing about wildly at night. Patients with Lewy body also have autonomic instability. They're very prone to orthostasis. And so these are the patients that fall. They fall all the time. They fall it's much more common than in Alzheimer's disease. It's such a profound clinical feature that my guess is that eventually these diagnostic criteria are going to have frequent falling as one of the criteria. And so that might be because of the autonomic instability. That might be because of the orthostasis that they suffer. It could also be because of the Parkinsonism. They kind of shuffle along. They can't pick up their feet well. Regardless, autonomic instability is another key feature. And then finally, perhaps they have a greater rate of decline. This is kind of controversial. Earlier studies showed that patients with Lewy body disease decline faster than those with Alzheimer's. More recent studies have argued against that. So they may have a greater rate of decline. Regardless, most people would agree that this is, even if it's not a greater rate of decline, it's a much more challenging disease to treat. And so in dementia with Lewy bodies, if you look at their we're in a church. It's God's. So we're going to talk a little bit about the pathology. And so if you were to look at these people's brains under a microscope, what you'll see are these inclusion bodies here. These cytoplasmic inclusion bodies. And these are the Lewy bodies. So it's called dementia with Lewy bodies. And the reason is they got these things here, and they're called Lewy bodies in their brain. And so these neuronal inclusion bodies, they'll be distributed in the dorsal motor nucleus of the vagus, the locus ceruleus, the rhombic nucleus, hypothalamus, basal forebrain, amygdala, and temporal cortex. So the vagus nerve, that's the nerve that helps to regulate GI function and heart function. So one of the things we know about dementia with Lewy bodies is that they have this autonomic instability. So perhaps that's because these Lewy bodies are disrupting neural function in the motor nucleus of the vagus nerve. The locus ceruleus, that's the nucleus in your brainstem that norepinephrine comes from. The rhombic nucleus is where serotonin comes from. Hypothalamus is involved in autonomic activity. The basal forebrain, this is where acetylcholine comes from. And again, early onset, or early in the course of Lewy body dementia is when we see cholinergic loss. The amygdala is what mediates these fear-based, these primal fear-based reactions that we're all capable of having. And the temporal cortex is memory as well as personality changes. And so this is in contrast, this right here, a Lewy body, is different than what we see in Alzheimer's disease. And so in plaques, these beta amyloid, these amyloid plaques, and we'll see tangles, which are intraneuronal protein, intraneuronal protein synthesis going on. And so with Alzheimer's disease, you see plaques and tangles. In Alzheimer's disease, it's the tangles will correlate with dementia severity. So in Alzheimer's disease, the more tangles a person has, the more severe their dementia. The plaques don't seem to correlate as well with dementia severity relative to the tangles. Now, patients with Lewy body dementia, they can have plaques and they can have tangles, but in patients with Lewy body dementia, it's the Lewy bodies that correlate with dementia severity. Even when compared to tangle burden, it's the Lewy bodies that seem to that better predict cognitive decline and functioning. Other features in Alzheimer's disease, this is the cross-section of your hippocampus. And so in Alzheimer's disease, the CA1 region of the hippocampus, this is the region that is mostly responsible for encoding memories. This is the region that's affected in Alzheimer's disease. But in dementia with Lewy bodies, it seems to be a little more anterior. The CA2-3 region is what's affected. So again, what I'm wanting to impress upon you is that in dementia with Lewy bodies, their cognitive profiles are different, their behaviors are different, the pathology is different, and so maybe the treatment plan should be different as well. We could talk a little bit about the cholinergic hypothesis in Lewy body disease. You know, if I was talking to residents on our consult service, I was talking to residents on our hospital consult service, and I would tell them that there's a patient who has fluctuations in consciousness and profound visual hallucinations, and they don't have any level of alertness. What is that? And immediately the residents on the consult service would say, oh, well, this is a delirium. You must have a patient that's in the intensive care unit or somewhere else in the hospital, and they have a delirium. And what we know about delirium is that there's an imbalance in the ratio between dopamine and acetylcholine. And so in delirium, dopamine tone is too high and acetylcholine tone is too low. So one of the fastest ways to give a person a delirium is to give them an anticholinergic, for example, Benadryl. We'll see this sometimes in older people who take Benadryl to help them sleep at night. Benadryl is very anticholinergic and it'll cause these same symptoms, this fluctuation of consciousness, these hallucinations, this disruptive behavior. And so if you give what we know about cholinergic toxins, cholinergic toxins affecting the base nucleus causalis of minor, these impair attention. They don't really impair memory, but toxins will impair attention. And again, in these neuropsych testing on Lewy body patients, they have impaired attentional processes. And we also know that profound cholinergic loss occurs early in dementia with Lewy bodies and late in Alzheimer's disease. So what this again suggests is that, while we hoped that acetylcholine would explain Alzheimer's disease, it didn't really seem to do that. But in a way, it seems to explain dementia with Lewy bodies even better. The same clinical picture of an anticholinergic delirium is the same clinical picture that we'll get with dementia with Lewy body disease. And so anticholinergic agents elicit hallucinations, fluctuations of consciousness, more commonly known as delirium. Cholinergic depletion of the basal forebrain may be responsible for these hallucinations in the Lewy body. And then, perhaps, cholinesterase inhibitors, what seems to happen is that cholinesterase inhibitors improve attention, hallucinations, and alertness in dementia with Lewy bodies. And these cholinesterase inhibitors, again, these are medications like donepezil and Aricept, galantamine, ribostigmine, these medications that are commonly prescribed for Alzheimer's. So we'll shift a little bit to treatments for Lewy body. Again, a lot of these are off-label. And we'll begin with the acetylcholinesterase inhibitors. And so there's been a pretty nice study that was done where they compared each of the acetylcholinesterase inhibitors in patients with Lewy body disease, looking at the mini-mental, a Parkinsonism score, and a behavioral score. And so this is the results for the mini-mental. Before I go on, I need to say that this is a summary of the literature. These are not head-to-head comparisons. So you can kind of look at the most appropriate way to interpret this graph is to look at each of these curves individually, but not necessarily to say, for example, that in this case, donepezil is better than ribostigmine. These aren't head-to-head trials. These are 3 separate trials. But nonetheless, what you'll see with the mini-mental is for some of these medications, in this case, the donepezil, you can see that their mini-mental scores do improve with acetylcholinesterase inhibitors. They also improve with the ribostigmine. And then perhaps, at least initially, with the galantamine. So when you run the statistics, each of these actually showed improvement relative to baseline performance. The improvement's small. This is a cognitive measure. The improvement's small. But nonetheless, there was detectable improvement for each of these. Where you don't see improvement is with Parkinsonism. And so again, one of those 3 core features of Lewy bodies is Parkinsonism. Parkinsonism, fluctuations, and hallucinations. And acetylcholinesterase inhibitors don't seem to have any benefit on Parkinsonism. But perhaps where they have the most benefit isn't with cognition. It's certainly not with Parkinsonism. But it seems to be that the most benefit that these have is with behavior. And as a psychiatrist, that's the whole reason that people are coming to my clinic anyways, is because of disruptive behavior, right? So what we see is, as measured by the NPI, each of these acetylcholinesterase inhibitors seems to improve. The lower your NPI score, the better your behavior. Each of these acetylcholinesterase inhibitors improves behavior during the course. And because of that, perhaps we can avoid some more toxic medications like the neuroleptics, the risperidone, the olanzapine, the haloperidol. Perhaps we can avoid some of those medications and instead use the acetylcholinesterase inhibitors. Just briefly, other treatments, neuroleptics. Again, one of the typically it tends to be more non-psychiatry physicians, I should say, tend to reach a little bit quicker for neuroleptics in dementia with Lewy bodies. And again, the reason is because they're psychotic. So usually psychiatry is really easy. If they're depressed, you give them antidepressant. If they're psychotic, you give them an antipsychotic. So in patients with dementia with Lewy body disease, they're highly sensitive to dopamine blockers. And in general, these medications should be avoided. In general, they should be avoided. Sometimes we'll go ahead and reluctantly use them and try them, but in general, we try and do everything we can to avoid neuroleptics. For these visual hallucinations, for example, for the patient that we discussed at the beginning, what we'll do is try and get a sense of how are these hallucinations impacting their life. And a lot of times they're not. So for example, if a person sees cats, well, the cats aren't trying to hurt them. They're not afraid of the cats. If they're chasing the cats out into the highway, well, then maybe that's a problem, right? And we need to target that. But if the hallucinations aren't impairing their life, they're not presenting a safety danger, a lot of times we just let them go. So my patient, he looks out his back window, he sees gorillas in the backyard. fine. Other treatment strategies that are sometimes used, again, the Parkinsonism medications, levodopa, carbidopa, it's generally well tolerated. It doesn't seem to make the hallucinations worse. This is in contrast to the dopamine agonists, like amantadine, for example. So it's well tolerated. It doesn't seem to make things worse. However, it's not really clear that it makes anything better. And then finally, benzodiazepines. Probably the one we use most commonly would be clonazepam or Klonopin. And the reason we'll use that is that it seems to be uniquely effective for this REM sleep behavior disorder. So we'll give them a little bit of clonazepam at night to help it. That's it. Any questions?
I have several. One, is this a genetic? Have they discovered whether this is a genetic?
Is it genetic?
Yeah.
The thought is that genes contribute, but that it's not genetic in the sense of like Huntington's disease. If you have Huntington's, it's caused by a gene mutation. You can nail it. It seems to be that there's genes that may make people susceptible to it, but then other things have to happen as well. And so it's one of those, it's like Alzheimer's disease. Is Alzheimer's disease genetic? The answer is sort of. For some variants, there's genes that absolutely cause it. But what seems to be the greater truth, what we typically think of as Alzheimer's disease, is that there's genes that make people vulnerable to it, and then other stuff happens, and then so certain genes seem to make people vulnerable to it, but it's not causative, unlike Huntington's disease, for example.
So then is it hereditary, where it's full moon?
Well, so susceptibility genes can be transmitted, can be passed on down the family line. So you can make the argument that people are more likely to be susceptible to it if they have a first-degree relative who has it. But again, if they have a first-degree relative that has it, it's not at all guaranteed that they're going to get it. At all guaranteed that they're going to get it. We wouldn't recommend genetic testing, for example, for this, unlike Huntington's disease. And so while it's possible, it's just there's other stuff going on. It seems to be that there's other stuff going on other than direct gene interactions that are causing it.
Because I don't know.
That's right. Nobody here wants to get that.
Is there any symptomatic relief of the Parkinsonism then? If it looks like they don't respond well to the levodopa, carbidopa?
Sometimes they'll respond to these acetylcholinesterase inhibitors, which is odd because a lot of times they'll use anticholinergics for Parkinson's disease, right? We'll use like cogentin or something like that for typical Parkinsonism. Maybe we'll use cogentin. So is there any relief? I can tell you the levodopa, the Cinenet, when they give levodopa, carbidopa, the studies suggest that if there is a benefit, it's modest. Not really. Let's take a break at 9 o'clock. We'll do our next topic.